Hello, and a very warm welcome to this eCancer roundtable discussion entitled Quality of Life and Safety in Novel Therapies for Prostate Cancer, with some updates from the recent ESMO 2021 meeting. My name is Heather Payne. I'm a clinical oncologist from University College London Hospitals. And I am absolutely delighted to welcome and introduce to you now our panel. I can think of nobody else that I'd rather be discussing this with. We have two absolute experts, not only in the academic sense, but in that they have great clinical experience and are regularly seeing patients. So a huge welcome to Professor Alicia Morgans, who is a medical oncologist in Boston, and Professor Bertrand Tombal, who is a urologist in Brussels. Now, we live in exciting times for the management of prostate cancer. The last decade has seen an explosion of new treatments with significant evidence for benefits for earlier and combination therapy, for metastatic hormone-sensitive prostate cancer, non-metastatic and metastatic CRPC. We've seen these big differences in overall survival and other really important secondary outcomes. So I think, the general consensus for advice is that we treat our men early, and that increasingly we treat them with combination therapies. The advantages are undisputed, but with any change in management, and also because we are treating these men now for a very long time, we need to consider the therapeutic index and balance the potential additional side effects and impact on quality of life for our patients. And I think especially that with those with pre-existing comorbidities. Now, in this session, we're going to concentrate on this balance and discuss some of the new data presented at ESMO. So thank you so much for joining us. And just to set the scene, I'd like to ask both members of the panel, how would you define quality of life? I mean, it's so difficult, isn't it? Because none of us can walk in another man or indeed woman's shoes to be able to know what's important to our patients. So Alicia, how would you define what quality of life is?
So I agree with you completely that it is a hard construct to define, and it's really important that, as you said, we all recognize that we can't intuit the quality of life of another individual without asking. So that is important, that it is important for the patient himself, in this case, to really let us know what his quality of life is. I typically think of quality of life of being composed of several important constructs, one being patient-reported outcomes from the patient himself, really telling us what his quality of life is as it's determined on specific instruments that measure certain things like pain or overall quality of life, emotional and physical well-being and functioning. But also, of course, quality of life is the adverse events that we as clinicians measure, because those impact what a patient needs to do, whether the patient needs a dose adjustment, whether the patient's having a neutropenic fever, whatever it is, these also impact quality of life. And of course, the final thing are the things that patients think about, from my perspective, in their day-to-day lives, like whether there's work missed or stress related to needing to find childcare while they are at a clinic visit for an infusion or something of the sort. So it really captures all of these aspects of what it is to have that lived experience of being treated for cancer.
Thank you so much. It was beautifully put. Somebody, I think they were a sort of philosopher type person, once said to me that quality of life is the extent to which hopes and ambitions are matched by experience. I think it just summed that up so beautifully with all of those things. Bertrand, how would you define quality of life? Anything else additional to say?
Yeah, I think first of all, we are in the concept of health-related quality of life. Actually, if somebody loses job while he's on treatment, it is not health-related. This is job-related. So what we are actually measuring is the impact on the treatment we're given on broad range of physical and mental processes that goes from your ability to have a social life, your ability to carry on your regular activities, or you feel, and then a lot of what we usually call symptom scale, meaning the direct impact of the adverse event. A good example is that, for instance, we're going to speak more and more about cutaneous toxicity, rash, but some people may find that rash absolutely not bothersome, and other may be absolutely bothered by grade 1 rash. So in contrast to the side effect, which is a rigid measurement of a symptoms or a sign using standard scale, the quality of life, I define that as the global impact on your ability of living a normal life, resulting from the disease itself and from the treatment we give.
I mean, I completely agree with you, because it is how these things affect people, isn't it? It's how they deal with them much more. And, and as you say, we can measure grade 1 to 5 toxicity, but that's going to be so different for each individual man. Could I just ask you, how we obviously in clinical trials, it is very important to be able to measure health-related quality of life, to be able to compare the effects of one treatment over another. What do you think about the measurements used in clinical trials? What are the commonest ones that we read about, and what do they mean?
I mean, from the European side, we usually use as the standard the tools designed by EORTC, which are a general quality of life questionnaire and specific questionnaire. But if you take, for instance, a prostate cancer patient, that's a set of 55 questions. It's not designed to be used in the clinics. It's designed to be used in clinical trial. So in the clinic, we usually rely on a simple form of questionnaire, and all our patients, we use the EQ5D5Ls. It's not technically a quality of life questionnaire, it's a health status questionnaire, but I find that question, how have you been feeling in the last few months or few weeks, something that should be automatically inserted in every anamnesis, because that's really the trigger to dig into what's happening. Because if the patient has been feeling perfectly well, I would even tend to say it means that toxicity are probably not that severe. So these tools are fine. And my dream is that to show that actually you can even sometimes predict progression by this simple set of questions. So this is something we need to improve, and we're going to move to simplest tool to detect these important changes.
Thank you. We for a while had a system where asking patients the 3 most important things in their life, and then to sort of grade how close they were to being able to achieve those in the ways that they wanted. And it was quite useful, because whoever picked up the notes then had that little bit of insight into what was important to that person. And they were incredibly varied, the things that people felt were important, but it was a useful lesson. Alicia, how do you measure quality of life in clinic? Because you say, we hand out all these FACT-P tools and pain inventories, but we can't do that. It's not fair on patients in everyday life. So what would your tips be?
Well, I think for each clinical practice, they may use sometimes a homegrown questionnaire, but to make sure that they touch on those points like pain, like distress, emotional distress, I think of particular importance is really critical. The NCCN in the United States has a distress thermometer that has been recommended almost as a fifth vital sign to collect, to understand where a patient is on the global scale, which is similar, I think, to what Bertrand is mentioning, that to get that insight into whether a patient is having some extreme either emotional or physical or symptomatic distress is really helpful. But there are a number of organizations like SIOG, which also suggests, particularly for our elderly patients, that we really do a systematic assessment. And they actually, I think, recommend the G8, which is a brief assessment of nutrition, function, polypharmacy, includes 8 questions, and then even a mini COG, which is a maybe 3 to 5 minute assessment of a patient's memory and ability to kind of plan to draw a clock. And I think that these simple things, particularly in our older adult patients, can be helpful as we're trying to not only understand their overall quality of life, but also understand, are they thinking as clearly as we hope? Can they make these treatment decisions? Do they need more support at home? And try to identify some red flag areas. But like Bertrand, I agree that these measures of quality of life really can track with disease progression, and change in quality of life has been associated with survival. So we, I think, as an organization of oncologists, urologists, and those who care for men with prostate cancer, should continue to investigate this and to understand the prognostic ability of these measures in our clinical practices so that we can really best support our patients.
Thank you. They're really useful tips. And as you say, very quick to do, but you gain so much information and insight, and also just to see how patients are tolerating treatments. Because often it's more than the PSA and alkaline phosphatase, isn't it? If they're, especially when we have such choice of the treatments we could give. Thank you. Bertrand, what do you think we've learnt in the last 10 years about quality of life, especially sort of looking at some of the novel therapies? What have we learned? What have they taught us?
I would say in the next 10, what we learn is that we still confounding a lot side effect and quality of life. And many times we hear like the quality of life of that combination is acceptable. Yeah, but that's a number. So as a community, we have to recognize that we're treating generally elderly people, average is usually around the 70s. So we really need to put an effort to define acceptability more than by, giving number of side effect. Yeah, it is acceptable. We can say it's acceptable to get 5% death. No, we need to better design tools. And like Alicia mentioned, we need to get single items that can help us define what is that acceptability. I see so many combinations with that is good, it's safe, it's tolerable, it's acceptable. These are qualifications. Actually, we have never, as a community, organized kind of an APCCC on what is acceptable for these patients. And that's a work where we're going to have to put patients in, because we cannot decide for the patient. And that's going to be a very heterogeneous work. But I think that's an effort we need to do, because, some of these combinations I read acceptable, then I look in detail and I say, wow, my God, that's kind of pretty toxic.
Yeah, I think, yes. I had exactly the same thought reading through some abstracts earlier this week. It's a really, really good point. So thank you both so much. And for the second half of this session, we're going to think about some of the new data from ESMO. And obviously, we've seen some stunning reports from trials with survival benefits and with delays in progression. But there have also been quite a number of abstracts, thankfully, that have concentrated on quality of life. And Alicia, which of the abstracts and presentations do you think were really important from this ESMO?
Well, I absolutely think that there were multiple. And so I'm happy that we as a team get to go through all of them. One of the ones I found especially interesting as we think about PARP inhibitor treatment with health-related quality of life was the GALAHAD quality of life data that really focused on treatment with niraparib in men with metastatic castration-resistant prostate cancer. And what they did was actually look at the quality of life for patients who had mCRPC and DNA repair defects, and broke those patients into patients who had BRCA DNA repair defects versus other, which of course include things like ATM, CHEK2, PALB2, and some others that were included, of course, in the GALAHAD study. What they found was that patients who had BRCA alterations had better quality of life. And I think we, as we think about this, can recognize that similar to other settings where we have better disease control, we will have better quality of life. It seems the same in this setting. When a drug is particularly effective against these targetable alterations, and BRCA2, I think, is probably the most affected by these approaches, patients will have better disease control, and in most cases will report that they have a better quality of life, including better pain control and overall quality of life. So we did see that here. And although it's something that perhaps we should have predicted was maybe obvious, I think it's great that the investigators actually measured it and then actually analyzed and reported it in a way that puts that concept into our heads and really drives that home.
Thank you. I think it's also a really good point, isn't it? That, you know, sometimes we look at the side effects of treatment, but often it's actually treating the underlying disease, because progressive cancer can have the biggest impact on quality of life than many of certainly a lot of the, you know, better tolerated compounds that we can give now. Bertrand, what was one of your top quality of life abstracts in this meeting?
Actually, there's one little one I like because it drew attention to something we usually don't do well. It's the poster 1419 depression and anxiety in prostate cancer patient, analysis of possible factor and correlation. Actually, we learned that it's quite often that patient will report mild depression or anxiety. And this is different stage of patient, and you can understand. And we usually assume that you tell somebody you got cancer, you're going to need surgery, they are anxious. But my worry is most of the time we do nothing about this. So this author, they show that actually a large majority of the patient actually report at least mild anxiety and mild depression. They use a very simple primary care tool. As mentioned by Alicia, there are tools existing for cancer patients such as distress. So we need to get used to implement these tools in our clinic, because seeing that we're going to add on top of that androgen deprivation therapy and other hormones which are known to increase anxiety. So I like that kind of small poster because it's usually brought very important practical point, especially to the young generation and people who discover these new drugs. Depression and anxiety are major problems that need to be tackled. I'm privileged to live in a country where we've got psycho-oncological support from the state. So you need to put that in your practice. It's not about making the life longer, but having an acceptable and an enjoyable one.
Thank you very much. I think I'm very intrigued by the distress thermometer, but I'm going to be Googling that as soon as we finish. And I think that's, you know, thank you, because that's something I'm going to take away from this and try and use in my clinic in the future. Alicia, what else was there at ESMO that you're interested in?
I really found that the poster that was describing the quality of life in elderly patients receiving chemotherapy as compared to younger patients was just an interesting concept, and was also a really interesting approach. So this was a group from Spain who used some previously reported data from the MAINSAIL trial, Enthuse, as well as Venice, and all of this is in a database that can be accessed free of charge. It's called Product Data Sphere. I think one needs to apply to have access to this data, but I believe it's free. And it allowed these investigators to pool 3 studies of men who were receiving chemotherapy and do an analysis, which I think is actually great for our field, to be able to share data in that way and to be able to look at it to answer some of these important questions. What they found from an assessment of patient-reported outcomes rather than adverse events in this was that both men who were older and men who were younger in this population did experience some benefits and some complications as it relates to their patient-reported quality of life. And there were slightly fewer patients who reported an improved quality of life when they were treated with chemotherapy, and slightly more patients who reported an impaired quality of life during chemotherapy for the older population as compared to the younger population. But in both groups, there were definitely patients who had an improvement in their patient-reported quality of life, which I think the authors point out is important to recognize that even older adults, and in this case, they were over 75 years of age, can experience improvement during treatment that may seem harsh, but particularly, again, if we're getting good disease control, may improve their quality of life. And so understanding which older adults are going to be able to take chemotherapy or whatever our treatment may be is going to be important, that we can't just look at a number. We have to look at the individual and his fitness for treatment and make those decisions with him, and that there are some patients who can improve. And I think that was a really important concept.
I mean, that's hugely important, isn't it? And also from your mention of CEOG earlier, I would recommend anybody who's never been onto the CEOG website to have a look at the information there. And the whole concept of CEOG, that there are older men who are vulnerable with comorbidities, but sometimes this gives us the opportunity to treat their comorbidities and to make them fit enough to receive treatment that's going to help their cancer. So I think that's a really important concept. And I love that abstract as well. I thought it was, in its patient selection and optimizing that man's health. Bertrand, you're very involved with CEOG, aren't you, as well? But great work.
Thanks.
But any other abstracts that you would like to? I think you had another couple.
Yeah. I usually like to look at additional analysis of the big trial, because usually if you look at large trial and you look at the primary New England Journal of Medicine paper, you usually get the top evidence. But like I said, the devil is in the details. So I like the poster 630p, which is actually the time course profile of adverse event in the ARAMIS trial. Why is it important? Because we speak a lot about this non-metastatic CRPC patient. It's true that the 3 drugs increase overall survival, but when you look at the treatment duration, we are way beyond 2 years, sometimes 3 years. I personally have patients on enzalutamide for 7 years now. So the time course of the adverse event is extremely important, because it's difficult to compare even the placebo and the active drug in this phase 3 trial, because the duration of treatment is so different. There were different ways to measure the quality of life and the adverse event in this T trial. So actually this reanalysis from the ARAMIS trial was really interesting, because it showed that basically if you apply a technique to look at the interval between entering the trial and the adverse event, basically you realize that actually the difference between the placebo and the active drug, in this case here, darolutamide, is actually very, very low. So that we are speaking of drug which have rarely more than 5 to 10% difference with the placebo. So it shows that over the time there is no accumulating toxicity. So clearly it shows that these drugs are really safe. And I think it is reassuring because we are speaking about patients who usually have no symptoms at all. We have noticed that the standard quality of life tools we use actually are not even probably sensitive enough to detect small differences because they were actually designed for patients receiving chemotherapy, radiotherapy, surgery. So it's very reassuring. And I many times listen to people who say, oh no, I'm going to delay the treatment because this is toxic to the patient. I think honestly, better than that, it's going to be very difficult to do. So when you look at these ARAMIS data with darolutamide, over a period of 2 years, you close to the point of detecting no difference. So really, it's very reassuring for those who want to use these drugs.
Hugely so. And I mean, it's so good now that we have a choice of drugs that we can match to patients' comorbidities and expectations. Was there another study that you'd like to tell us about?
Yeah, it's about the health-related quality of ACIS. I must say that if you have to put ACIS in perspective with the AB plus minus ENZA arm of the Stampede that was presented by Gert Attard, because to me it's a very important trial. Actually, that's an old idea. It's the idea of combining apalutamide and enzalutamide with ABI. I must say, I'm not really convinced about the combination because I'm surprised that here when you add apalutamide and abiraterone acetate, as you know, there was a benefit in PFS, a small benefit in OS, that actually in my country would never reach the level of reimbursement, if I may say. There was some additional toxicity. So here I was quite surprised, and sometimes I was quite surprised that actually there is no big difference between the two drugs. But then when you're digging in, you actually realize that we may be in one of these lack of sensitivity of the tool they're using. For instance, and we know that very well with enzalutamide, we just published a paper on that actually, if you use single question in the quality of life domain for like this one, which is commonly used now, which is the lack of energy question, actually most of patients, you've got a ceiling effect. Actually, 90 to 96 patients here of the patient report not a whole or a little bit. So you've got a ceiling effect. So I still have some doubt about the real impact on this combination on the patient toxicity and quality of life. I think we need more precise tool to measure that. And my simple demonstration of this is that actually, if you look at what is reported by Gert Attard, you have almost a doubling on the side effect in the ENZA abiraterone arm in the Stampede trial. And I like Stampede because Stampede is very close to real world evidence. So I'm not still absolutely convinced by the fact that there is any role to combine these two agents today.
Thank you very much. And again, of course, being British, I love Stampede. It's our sort of national treasure. But interesting, and I'm sure that we're going to be seeing, well, we are going to be seeing more trials coming through with these combination therapies. Alicia, I think we've got time for one last study. What would your next important one be?
there was another study, the Tasmastat combination with abiraterone and enzalutamide, that I wanted to mention in men with mCRPC. Importantly, this was not patient-reported outcomes. This was really just a new combination for us as clinicians to think about coming down the road. They did find in this study that they were able to get a good recommended phase 2 dose, and there was really no dose-limiting toxicity, which is important. And the purpose of this study was to demonstrate tolerability, but to Bertrand's point, it's tolerability by the CTCAE in terms of adverse events. It is less common, of course, that we put patient-reported outcomes into these phase 1 trials. And so perhaps that's why this was not part of their design. But importantly, they did demonstrate that relatively few patients had serious adverse events, around 14 to 15% in the combination of tazemetostat with abiraterone and in the combination of tazemetostat with enzalutamide, suggesting that for a majority of patients, there won't be grade 3 and above adverse events that will really limit their tolerability or impact their patient-reported outcomes. So we will have to see, but that relatively low event rate, I think, is intriguing and does bode well for this combination moving forward into later phase studies over time.
Thank you so much. Another great abstract and study, and one to look out for future reporting. The time has just flown by. I can't believe how quickly that's passed. And on everybody's behalf who's been listening, thank you both so much for some really wonderful insights and good tips to take with us for monitoring our patients' quality of life in the coming months and years. So thank you so much for your attention. We hope to see you soon. And in the meantime, stay safe and well. Thank you and goodbye.
Thank you. Bye-bye.